The conventional pacemakers consist of one or two leads, which are usually introduced by preparation and incision of the cephalic vein and/or puncture of the subclavian vein. The standard location of the leads in dual-chamber pacemakers is the right atrial auricle and the outflow tract or the apex of the right ventricle. Panel A shows a single-chamber cardiac pacemaker with a lead placed in the right ventricular outflow tract, and Panel B shows a patient after implantation of a dual-chamber pacemaker with leads in the right atrium and the right ventricular outflow tract. For the full understanding of further issues, it is worth emphasizing that the primary function of a cardiac pacemaker, as its name implies, is cardiac pacing. Pacemakers are used to treat symptomatic or prognostically significant bradycardia. This may result from sinus node disease, atrioventricular block, and from an intensified cardioinhibitory component in the course of reflex syncope. It is worth remembering that in the case of sinus node disease, cardiac pacemakers do not improve survival. Bradycardia can result from a number of reasons, which can generally be divided into extrinsic and intrinsic. Among the extrinsic causes of bradycardia, we distinguish idiopathic atrioventricular block, vagal reflexes, intensive chronic physical training, metabolic disorders, drugs, obstructive sleep apnea, neurological disorders, and electrolyte disturbances. In contrast, intrinsic causes of bradycardia include ischemic heart disease, congenital heart disease, some infectious diseases, iatrogenic causes, connective tissue and infiltrative diseases, and rare genetic diseases. Interestingly, bradycardia in the later cases may coexist with features of preexcitation. The intrinsic causes of bradycardia are especially a potential indication for treatment by cardiac pacemakers, whereas in general, we should not implant pacemakers to treat reversible causes of bradycardia. This applies to patients with reversible causes of sinus node disease as well as to those with reversible causes of AV block. Bradycardia may manifest as symptoms associated with cerebral hypoperfusion and as symptoms associated with other mechanisms. The former includes syncope or presyncope, dizziness, and blurred vision. Other symptoms include shortness of breath and reduced exercise capacity. In patients with persistent bradycardia, the diagnostic process is often of short duration, while for patients in whom bradycardia occurs only periodically, that is, it is intermittent, the diagnostic process can be prolonged and sometimes requires a number of additional tests, including prolonged electrocardiographic monitoring, electrophysiological study, carotid sinus massage, or tilt test. The 2013 European Society of Cardiology guidelines for patients with persistent bradycardia due to sinus node disease recommend cardiac pacing when the symptoms may be attributable to bradycardia. However, cardiac pacemakers may be indicated in patients with sinus node disease when their symptoms are likely to be the result of bradycardia. Dual-chamber pacemakers with spontaneous atrioventricular conduction are preferred in these patients. If, in addition, patients have chronotropic incompetence, the use of a function to increase the frequency of cardiac pacing in response to exercise should be considered. This is called the rate response function. In patients with acquired second-degree atrioventricular block type 2 and third-degree atrioventricular block, European Society of Cardiology guidelines recommend cardiac pacemaker implantation regardless of symptoms. For second-degree atrioventricular block type 1, cardiac pacing is indicated if it is symptomatic or is located at or below the bundle of His in electrophysiological study. Similar to patients with sinus node disease, patients with atrioventricular block and sinus rhythm are also considered for dual-chamber pacemaker implantation. However, If atrioventricular block is accompanied by persistent atrial fibrillation, then, as a standard of care, the patient should receive a single-chamber ventricular pacemaker with a rate response function. The European Society of Cardiology guidelines from 2013 for patients with intermittent and documented bradycardia distinguish several groups of indications for cardiac pacing. For patients with sinus node disease and symptomatic bradycardia in the course of sinus arrest or sinus atrial block, the guidelines recommend cardiac pacing. Pacing is also indicated in patients with intermittent or paroxysmal intrinsic third-degree AV block or second-degree AV block. Recent guidelines from the European Society of Cardiology on the diagnosis and treatment of syncope from 2018 have specified the indications for cardiac pacing in the treatment of reflex syncope. Generally, in this group of patients, one should or may, depending on the cause of the syncope, consider permanent cardiac pacing, usually in patients over 40 years of age. Cardiac pacing seems particularly indicated in these patients if there is a recurrence of unpredictable syncope or if symptomatic asystolic pauses above 3 seconds or asymptomatic pauses above 6 seconds can be demonstrated. The exception is recurrence of syncope in patients with the clinical features of adenosine-sensitive syncope. The 2013 guidelines of the European Society of Cardiology recommended that in patients with syncope, an asymptomatic pause lasting more than 6 seconds may be an indication for cardiac pacemaker implantation. However, it is worth emphasizing that more recent recommendations suggest cardiac pacemaker implantation in patients after syncope with accompanying sinus node disease and asymptomatic pause already greater than 3 seconds. Of course, one should first exclude alternative causes of syncope and arrhythmias, such as hypotension, medications, and training. European Society of Cardiology recommendations underline the importance of dual-chamber pacemaker implantation with maintenance of spontaneous atrioventricular conduction and or spontaneous sinus rhythm in patients with reflex asystolic syncope. It is worth remembering that chronic right ventricular pacing can lead to right ventricular pacing-induced cardiomyopathy and should therefore be avoided if not needed. According to the recent ESC recommendations, cardiac pacemaker implantation is not the first-class recommendation for any type of reflex syncope, and in patients qualified for permanent cardiac pacing, it is crucial to show spontaneous or induced asystolic pauses. The assessment of indications for cardiac pacing in patients with bifascicular block is a different issue. According to the 2018 recommendations of the European Society of Cardiology, we diagnose bifascicular block in the case of a left bundle branch block or right bundle branch block concomitant with left anterior or posterior fascicular block. The figure shows an ECG with bifascicular block consisting of a right bundle branch block and left anterior fascicular block. This diagnosis is supported by findings which are characteristic for right bundle branch block, such as prolongation of QRS complex duration over 120 milliseconds, R-wave peak time in V1 above 50 milliseconds, presence of broad S-waves above 40 milliseconds in the first lead and V6, QRS complex morphology of RSR' in V1, and secondary STT changes in V1. In the context of these changes, we recognize a left anterior fascicular block by a left axis deviation, QR complexes in AVL, and R-wave peak time in this lead above 45 milliseconds. In patients with unexplained syncope and bifascicular block with a reduced left ventricular ejection fraction of 35% or below, we should consider indications for implantation of an ICD or CRT device. In contrast, for patients with higher left ventricular ejection fraction, empirical cardiac pacing may be considered. Such treatment may be particularly justified in elderly patients at high risk of syncope recurrence leading to injury. Generally, however, patients with unexplained syncope and bifascicular block should be referred for electrophysiological study and, in the case of a negative result, for placement of an implantable loop recorder.